We're going to go through the slides kind of quickly. There's just a lot of graphics and visuals to make it easy for everybody to understand. And then at the end of the 60-minute presentation, we'll have 20 minutes of questions and answers. My bio is available online for those of you who are interested in learning a little bit more about my background. A little bit about my practice. As I said, I'm an orthodontist in private practice by myself in South Miami, Florida. My practice is we treat children and adults, but it's mostly heavily a pediatric population. Probably 75% of all of our new patients are in the mixed dentition. I'm pretty involved in the didactic orthodontic curriculum at Miami Children's Hospital Department of Pediatric Dentistry. I started using 3D imaging, known as CBCT, sporadically in 2007 on some isolated cases, more complex cases, impacted canines, orthodontic surgery cases, TMJ cases. And in 2009, I quickly converted completely to 3D imaging. I acquired our first iCat machine. And at the time, it was a very kind of symbolic mark in my practice because at that moment, we got rid of our 2D imaging system, we got rid of our Panorex and our cephalometric machine, and we went fully in with 3D on every case. So there are many advantages to 3D imaging. First of all, it allows us to see our cases in the third dimension. We are, after all, 3D patients. It allows us to see and understand our patients' anatomy in a distortion-free way, enlargement-free, with no ghosting. Secondly, it allows us, and as orthodontists this is very important, to understand our cases in the transverse dimension. It allows us to view the buccolingual dimension of the alveolus, of roots within the alveolus, how teeth are emerging and fitting within the alveolus. So from a periodontal perspective, that's very helpful. It also allows us to understand the TMJ status of every single patient before we start treatment. Now, while it does have its limitations, we get to see the hard tissue information of the temporomandibular joint, that is the condyle and the fossa. So we can screen, very importantly, for cases that have underlying degenerative joint disease in an active or non-active form. And what's interesting is there's a lot more DJD cases, degenerative joint disease cases, out there than we ever thought. And the scary part is that many of these cases are kind of flying under the radar because they're completely symptom-free. So it allows us to screen for arthritic joints, arthrotic joints. We want to know what kind of condyles we're dealing with prior to the start of any type of invasive treatment, whether it be orthodontics or restorative dentistry. So in a nutshell, it really improves the diagnostic power of our treatment. But the one area that has affected my practice and kind of changed the way I really practice is the airways. It's the one benefit that 3D imaging offers that 2D imaging cannot. And what I've learned so far in my last 5 or 7 years of practicing exclusively in cone beam, if there's one piece of information, is that it's all really about the airways. And we're going to really focus on that element of 3D imaging for the rest of the presentation. So if you think about it, breathing really is the foundation of life. And breathing is a function of anatomy. In fact, it's a function of craniofacial anatomy. And as orthodontists and as dentists, who better is positioned to screen for patients that have sleep disorder, breathing problems, such as sleep apnea? Because only us can fully understand occlusion, facial profiles, skeletal profiles better than our medical peers most of the time. So we're going to do a quick anatomical review of the airway. In my training in dental school, I always kind of imagined that the pharyngeal airway was this rigid tube that air passed through, and it's really far from that. It's a soft tissue, very dynamic airspace left over from all the structures around it. So it's a very kind of dynamic structure, and we have a lot more influence on that pharyngeal airway than perhaps most of us have realized. So I want to share with you this video of the Korean man. He's probably the most famous cadaver in the world. This was a cadaver that had been kind of imaged to death, if you will, with contrast CTs and MRIs. And so what you can see here is the human pharynx, and really understand and appreciate how the space left over. Let me go back and do that. You'll get to really appreciate how the pharynx is really the space left over from all the tissues around it, with the biggest enemy perhaps is being the tongue. So we sometimes forget the enormous size of the tongue and the effect that it can have on our breathing. And so you can see how the tongue is, I'm sorry, this should not be cycling back and forth, but you can see how the tongue is held in position by the teeth. Let me disconnect the phone here, I apologize. Okay, so just real quickly, you can see how teeth are basically the anterior border of the tongue. And so where that tongue lives is totally dependent on the size of the oral vaults and the anterior position of the boundaries, which are essentially the anterior teeth. And so anterior teeth position come into play in orthodontics, because we're always talking about angulation of incisors, position of the mandible, and so remember that huge organ known as the tongue is attached to the inferior border of the mandible. So this conversation today is really going to be about three things: cone beam CT, anatomy, and airway. And it's really hard to separate the three. You almost have to almost consider these synonyms of each other. So René Descartes was a great philosopher from England who, of course, postulated the Cartesian theory, which stated, "I think, therefore I am." And René Descartes said that if any of us are to be true seekers of the truth, absolute seekers of the truth, then we need to question everything that we think we know. So while two-dimensional imaging, panos, and sets have served their purpose, they've taught us a lot, they do have their great limitations, and they've been replaced by newer technology, because this in the end is really 1948 technology. Cone beam CT now allows us to visualize patients in a much more holistic manner, bringing to light the very essence of the head and neck, which is the pharyngeal airway. And so we can now visualize the air spaces on every single patient through computer power, and make decisions and assessments about different sizes, shapes on patients' airways, and better understand their relationship to what we do. So this image that I just showed you is something called dynamic modeling, where cone beam CT is all the elements are segmented with special software, and this is an extended field of view scan taken on an iCat next generation machine. The radiation exposure, some people may be wondering, is about 65 to 7 microsieverts, depending on the settings that you choose for the individual scan. Okay, so kind of a game changer a year and a half ago when iCat revealed its newest machine. It's kind of the next generation in cone beam technology called the iCat Flex. The reason this is such an important contribution to technology is it has really lowered the radiation exposure on these cone beam scans. And there was a study that came out of the University of North Carolina from John Ludlow, where he validated and confirmed the extremely low radiation levels of the iCat Flex on an extended field of view. An extended field of view, of course, is a Ceph-size scan that can be titrated down to as low as 11 microsieverts. That's incredibly low, considering that a digital Panorex is about 24 microsieverts. So now we're talking about the possibility of having a 3D extended field of view scan with less than half the radiation of a Panorex. And so this dynamic model was taken on a patient using the iCat Flex. This was 11 microsieverts of radiation, and as you can see, it can give us a perfect pharyngeal airway. So it really becomes kind of a game changer in orthodontics. And it allows us now to visualize and treatment plan all of our patients in this manner, with the airway at the very core of what we do. Because as you will be hearing me repeat throughout the lecture, is that straight teeth are nice, but long, healthy lives are better. And you're going to hopefully understand here the impact that we as dental professionals have over the airway management and development of any patient of ours who have an airway, because we can now visualize it. So orthodontics is changing. Now we can look at the teeth and how they sit within the bone. We've always done that. We can just do it more accurately now without distortion. But we can now look at teeth and jaws and faces relative to airways. And it really offers us a more complete picture of the patient's holistic anatomy. So the one thing that's kind of evolving in my practice philosophy is, we're always taught the treatment plan from the outside in, and we look at patients and we look at their faces and we look at their smiles, which is very important. But what I'm trying to do here is kind of make a push for us to treatment plan, again, from the inside out, based on the airways. So let's talk a little bit about obstructive sleep apnea, OSA, which is a very hot topic now these days. First of all, there are approximately 80 different types of sleep disorders, ranging from insomnia to more serious conditions such as restless leg syndrome, narcolepsy, and sleep apnea. But obstructive sleep apnea, also known as OSA, is only about 40% of those sleep disorder breathing cases. From a financial impact on a society, the Harvard School of Public Health published a white paper on obstructive sleep apnea a couple years ago, and their estimated total annual healthcare costs of moderate to severe obstructive sleep apnea and its comorbidities are estimated to be between $65 billion and $165 billion alone per year in the United States. Very important to state that obstructive sleep apnea can only and should only be diagnosed by a medical physician, usually through a sleep study known as a polysomnogram or a PSG. Leave there no doubt about this, that obstructive sleep apnea is a medical problem, and as you will see today, with an orthodontic solution. Some alarming facts about obstructive sleep apnea. Left untreated, the average life expectancy of an overweight adult patient with severe OSA is about 10 years. Recent study came out, very important, alarming. 36% of patients who have 20 or more apneic events per hour, that's an AHI of about 20, which puts you at about moderate OSA, left untreated will be dead in 8 years. There's an 8 times likelihood of a fatal automobile accident if left untreated, because people fall asleep at the wheel. Once obstructive sleep apnea is reported to the insurance data banks, and they will, because the insurance data banks here in the United States are the insurance industry is what's paying for those expensive sleep studies. So all that stuff gets reported and shared with the policymakers for insurance companies, will negatively affect the ability for a patient to be underwritten for a life insurance, disability insurance, even medical insurance. Of course, there's a lot to talk out there about all the comorbidities related to obstructive sleep apnea, such as strokes, heart disease, heart attacks, congestive heart failure, hypertension, diabetes, diminished quality of life, depression, and so forth. Some epidemiological facts about obstructive sleep apnea. 1 in 5 Americans have mild OSA. 1 in 15 have moderate to severe OSA. And astonishingly, only 50% of the patients who have OSA have actually been diagnosed and treated. That means that 85% of the patients who have OSA are out there undiagnosed. And those 85 patients are very likely sitting in your practices. This number is growing about 15% per year, simply because of the public awareness being made by the healthcare practitioners. So we're going to talk about imaging today and the role that imaging plays in the screening of airway-related problems such as obstructive sleep apnea. But I want to make it very clear that obstructive sleep apnea cannot be diagnosed using any kind of imaging modality. However, obstructive sleep apnea and sleep disorder breathings have a strong anatomic component. There are other components which are very complicated, but we will be focusing on the anatomic component of obstructive sleep apnea. And that's where imaging can play a critical role. So a quick summary, there are basically 3 areas of obstruction in the upper airway. That can be the nose, the back of the throat, and the base of the tongue. That's it. That's where the airway is obstructed. And we can see the nasal influence of very deviated septum here. We can see enlarged adenoids that can create an obstruction, hypertrophic tonsils, which are very common in children, and of course nasal sinus disease, nasal cavity obstruction, something that the ENTs refer to as nasal crowding. But perhaps the single most greatest cause of airway obstruction is the pharynx. And so in the field of sleep medicine and sleep apnea, we talk about the smallest cross-sectional area of an airway, known as the MCA, and we're going to be talking about that term a lot in this presentation. So the MCA stands for minimum cross-sectional area, which ends up being the bottleneck, because it doesn't matter how wide a pharynx is. It's the only importance is the smallest area, because it's the bottleneck. Okay. So with technology now, we're able to measure the airway and get some very useful information about anatomy. So this is a particular software that we use called Treatment Studio that comes with the iCAD. And within 5 seconds, the touch of a button, we are able to segment the airway and isolate it and get something that looks like this. So this is a very important slide, because what we're looking at here is kind of a gradient measurement scale. So what the software will do is it will measure the cross-sectional area, hopefully you can see my cursor here, at every interval, and give us the value, which is in millimeters square, in the form of a color. And so you can see down here the conversion scale on the bottom. So values that are way to the right are very good, very excellent values, the black and the blues, and values that are way to the left are what we consider poor values. So we don't like to see values in the black or in the red, because they represent a very small airway. But the most important value or measurement that we get is this little red line, and I don't know if I have no, I don't. So this little red line represents that bottleneck area, which is known as the smallest cross-sectional area. And so there's a lot of good diagnostic information that we can get from this information, from this measurement. So let's talk about that measurement, that MCA. There have been studies, and again, we don't diagnose obstructive sleep apnea off of an X-ray, but there have been lots of studies, pretty important studies, that look at the markers, the correlation between the MCA and the risk factor for obstructive sleep apnea. And I've kind of simplified this a little bit for everybody, and just keep in mind the 50, 100, 150 rule. So those numbers go as follows. When the MCA is between 0 and 50 millimeters square, that puts the patient at high risk for obstructive sleep apnea. When the MCA is between 50 and 100 millimeters square, that gives us a moderate risk for OSA, and between 100 and 150 is considered a low risk. So what appears to be a safe number is anything above 150 millimeters. So that's just kind of a gross kind of marker that we look at on patients to understand the risk factor that they are in for sleep apnea. As far as how valid of a tool is cone beam CT in measuring these airways, well, the gold standard has always been MRIs and medical helical CTs. So lots of studies have compared the validity of cone beam CT with these gold standards, and have shown to be just as accurate. And the reason is, even though cone beam CT is considered a low resolution scan compared to medical CT, there apparently is no difference in its detection in its ability to capture the air spaces, understandably. So it does equally as good of a job as medical CTs in capturing the border detection of surfaces. So that's why we can capture the airway so crystal clear on these cone beams. So a couple considerations regarding airway assessment using cone beam CT. First of all, very important to understand that most of these cone beam CT units are stand-up units where the patient is upright and not laying down. So from the beginning, understand that we are capturing a best-case scenario every time we image our patients, because the patients are upright, they're not supine, they're not sleeping, and that's very important. the muscles of the pharynx are awake, they're alert, and they're active. Patients are, we are capturing the best case scenario. So it's possible to get false negatives, but we don't get false positives. In other words, when the airway is bad, we know that it's bad on the imaging. When the airway is good, it can still be bad. So we need to screen for the bad ones, and we need to be wary of the good ones. That's basically what that's telling us. So imaging protocol is very important. Standardization of how we scan patients must be considered. So what we've done in our office is develop kind of strict protocols. First thing we do is we put the patient in centric relation. We want to have a seated condyle the best that we can. So if a patient is posturing forward into, say, an underbite, that's going to give us an erroneous representation of the airway. So we try to control for jaw position. So jaw position is very important. The second thing we do is control for natural head position. So we just tell patients to sit up straight and pretend they're looking at the sunset on the beach. And that kind of gives us a natural head position. We don't want the patients tilting upwards or downward. That can also give us, that can change the shape and size of the airway. And probably the most important factor is tongue position. And as we said, the tongue is everything when it comes to obstructing the airway. So we want to capture, again, in line with our protocol of capturing best case scenarios, right? We want to make sure that tongue is upward and forward, up against behind the front incisors. So this is a very interesting slide because it shows, let me back up here, it shows a scan that was taken on a patient. And you could see the tongue position is kind of backward. The tongue, we do not do a good job controlling for tongue position like we should have. We'd like to see that tongue forward. So we don't like to see black spaces here right under the anterior part of the maxilla. And you can see the resulting segmentation of the airway. So we actually decided for other reasons to repeat the scan that day on the patient, and we did so with the tongue forward. And now you can see the difference in the airway measurement. So you can see there's no black space right here. The tongue is clearly resting behind the upper incisors. And let's look at the effect that that tongue posture has on the airway measurement. So you can see a volume changed from 26 cc's all the way to 35. But most dramatic was the MCA went from 198 to 285. So that just really tells us two things. Number one, tongue position is very important in controlling and standardizing imaging protocols. And secondly, the tongue is everything. So the tongue is a big culprit when it comes to airway obstruction. Here is an example of my particular scan, my own personal scan. And you can see here, for those that maybe aren't too used to looking at these images, this is a view from the bottom looking up, an axial view of my deviated septum. And I've suffered from allergies and mouth breathing all my life. And it wasn't until I scanned myself a couple of years ago that I detected this significant problem. Look at my turbinates. Here's a cross-sectional view, coronal view. You can see my enlarged turbinates. Sinuses look pretty clear, but I had, of course, severe nasal deviation with enlarged turbinates. I decided to have this corrected a few months ago, and I scanned myself post-surgically, and I'd like to share the results with you. So on the left, you see the image of pre-surgery. You can see the extent of the deviated septum. And on the right, I'm sorry, here's the coronal view. Let me go to the next slide here. Okay, here we go, the comparison. So on the left, you see pre-surgery, on the right, post-surgery. So you can see the effect that the correction of the deviated septum had on the size of my nasal passages. And it's been really life-changing for me to be able to now breathe comfortably through my nose and breathe through my nose, not snoring as much as at night. Not getting sick. I haven't gotten sick in probably a year since I had the procedure done, because we always try to encourage nasal breathing on patients. Nasal breathing is preferable to mouth breathing because it allows us to clean the air, filter the air, moisten the air, and warm the air. When we breathe through our mouth, we're essentially breathing dry, cold, infected, dirty air. So let's talk a little bit about the relationships between airways, jaws, and teeth in a nutshell. So this is kind of a complicated slide. It's very busy, but We think that allergies may play a significant role as the initial etiology on these problems. So it kind of begins with nasal obstruction early on, when children are born. They're allergic to many environmental allergens, ranging from food to pollens. And so chronic nasal obstruction obviously leads to obligatory mouth breathing, because patients have to survive. They'll compensate. So they become kind of chronic mouth breathers. Well, if you can't breathe through your nose and you're only breathing through your mouth, you have to lower your tongue posture, your tongue position. If your tongue is living in the roof of the mouth, then you're basically can't breathe through your mouth. So tongues don't live in the palate on these types of patients. And so what ends up happening is we get a lack of palatal development early on, and a lack of transverse development. So a lack of transverse development in turn leads to a constricted maxilla. Constricted maxillas in turn lead to problems such as crowding. In the mixed dentition, crowding is most of the time visible, at least in the maxillary arch, in the form of ectopic or impacted canines. So I'm more and more convinced some of the correlations that I'm seeing after practicing so many years with this stuff is impacted in ectopic canines many times. I won't say most of the time or every time, but many times correlate with narrow airways, obstructed airways, and mouth breathers. These, of course, in their dental problems, we know, can lead to all types of TMJ. Jaw hinge problems can affect the way the face grows, facial growth discrepancies, requiring more invasive treatments later in life. This slide here shows what the solutions are for patients, adult patients with obstructive sleep apnea. And they range from the least invasive, but quite possibly the most difficult, weight loss, all the way to how we sleep. It's recommended patients with OSA don't sleep on their back. They should sleep either lying face down or on their side. Of course, nasal congestions, oral appliances. We're going to talk a little bit about that. It's a very hot, controversial topic. CPAP machines, really considered the gold standard for the everyday common moderate to severe sleep apnea. When we talk about surgery for sleep apnea, there's really two kinds of surgery. There's soft tissue surgery, known as UPPP surgery, which is difficult surgery. It's not that effective, and it's very painful recovery. And then there's hard tissue surgery, known as orthodontic surgery, in the form of maxillomandibular advancement. Also can be a mandibular advancement, also known as bimaxillary advancement. And we're going to talk about how this is really considered the top-of-the-line, definitive, end-all, cure-all solution to obstructive sleep apnea. And then, of course, tracheotomies, which is just not practical for most patients who have sleep apnea, but it is performed. So let's talk about a little bit about oral appliances. Remind everybody again that I'm an orthodontist, so I'm looking at this from an orthodontic perspective. I've yet to find one single oral appliance in the market that is not a class 2 corrector. All of these appliances that I am familiar with move teeth. They are class 2 correctors. They posture mandibles forward, which is what makes them so effective. And when mandibles are postured forward, the masseteric sling tends to want to reposition the mandible back, and in doing so, the teeth get left behind and slide forward. The lower teeth slide forward on the denture. So here we have an example of this is actually a physician who was treated for snoring by their dentist and was very, very compliant. And this is, we got to image the patient. This is after 5 years of wearing his oral appliance every night. And as you can see, based on what we talked about the airways, he's got a great looking airway. His MCA is in a very good place. You can see these colors. Anything above the middle to the right is good. But he also has, so not only does he have an amazing airway, he has an amazing malocclusion. This is a patient who started with a class 1 bite and now is a full class 3 underbite, and came to see me because he was experiencing TMJ problems and changes in his bite, so basically a malocclusion. So a study from Lowell et al. Reported 85% of patients on oral appliances had tooth movements after 5 years. So the research seems pretty clear that you can expect teeth to move on patients who love their oral appliances. Of great concern is what's happening at the level of the condyles in the joint space. So as expected, this patient now has very enlarged joint spaces. You can see through the tomographs here. And so what happens now is the patient has acquired a new centric relation. And we now need to accept that position as the patient's new centric relation. He has a fibrotic disc. He has a new pseudodisc, really. There's an intracapsular and extracapsular component of this problem. The disc is now fibrotic and basically has hyperplasia of the retrodiscal tissue. And then more globally, there's an extracapsular component, which is muscular adaptation. These muscles, after 5 years, have been elongated and expanded to a new length. So it's fair to say this is irreversible at this point. That mandible is now positioned in its new jaw position, if you will. So you got to be careful with these oral appliances, and they need to be monitored. You need to talk to patients carefully about the problem. So just a word of caution for anybody issuing oral appliances: never issue an oral appliance on a patient without knowing what their something called the AHI is, the apnea-hypopnea index. You should be involved as part of the medical treatment or medical management of a patient with sleep apnea. These patients need to be diagnosed, have to have a proper diagnosis made on these patients prior to just issuing oral appliances. Their life is at stake. CPAP machines, very common, very effective. They basically keep people alive, and they extend their life expectancy and their quality of life. The only problem with a CPAP machine, according to different reports, is that only 50 to 70% of the population can tolerate CPAPs. So reports as high as up to 50% of the patients who need to be on CPAPs cannot tolerate them. So let's talk about what's considered perhaps by at least the literature, as far as the literature goes, the most effective, definitive, end-all, be-all solution of obstructive sleep apnea. And let there be no doubt about that, which is mandibular advancement or maxillomandibular advancement. So several studies, very well-controlled studies looking at controls with oral appliances, CPAP machines, and MMAs have looked at the effectiveness of MMAs and have reported success rates of 100%. 3 different studies have reported success rate of 100%. Rarely do you see anything work 100% in science. So keep that in mind. That's a take-home message. This is a classic study and one that really everybody needs to understand. This appeared in our Orthodontic Journal a couple years ago by Bill Prophet and Dan Grauer, 2 brilliant minds in our field. And they asked a simple question. Again, this was published in 2009. They asked a simple question: is there a correlation between dental facial patterns and pharyngeal airways? And it's really the first study to show us that there was indeed. And their conclusion was that airways can kind of be put into these categories. Now, the correlation is not 1-to-1, but it's very strong. So when we look at faces, when we look at skeletons, we can start kind of correlating airways. And what they found was that the convex profiles, meaning class 2 patients, appeared to have the smallest pharyngeal airways, followed by the class 1 straight profiles, orthodontic profiles, straight skeletons. And probably not surprisingly is that the class 3 patients with the strongest mandible, concave profiles had the best airways. So we can start looking at faces, we can start looking at occlusions, and start in our mind thinking about the airway on these patients. This study was repeated. What I like about these studies is they all used cone beam CT. This study was repeated by Abdul Karim, reported in the Journal of the World Federation of Orthodontics in 2012, and he reported very similar findings. Those conclusions were so important, and he laid them out so clearly that I'd like to review those. Pharyngeal airway volume was largest in the mandibular pragmatism group, that is class 3 patients, followed by normal mandible posture, meaning class 1 patients, and then the mandibular retrognathism group. So same conclusion as Prophet and Grauer. These results indicate that the AP, the anterior-posterior, the horizontal dimension of the oropharyngeal airway space is affected by different skeletal patterns of the mandible. So the mandible seems to be the greatest culprit in most of these cases. So small mandibles, retruded mandibles, think small airways. The pharyngeal airway should be evaluated in patients with mandibular retrognathism, class 2 patients, convex patients, especially in severe cases. If relevant snoring or OSA symptoms are present, consideration of a sleep study, including a PSG, can be beneficial for specific class 2 malocclusion patients with noticeable mandibular retrognathism. So really, in other words, what he's saying is when it comes to class 2 malocclusions, or really when it comes to any kind of malocclusion, we need to be looking at airways, and we need to be considering airways in the overall treatment planning of our patients, especially with children and especially in orthodontics. Another study using cone-beam CT by Martin Palomo showed the same thing. So there are three very powerful, well-controlled studies published in peer-reviewed journals, all of them AJO. One was the World Federation of Orthodontics, showing a strong correlation, which is consistent between pharyngeal airways and dental facial skeletal patterns. Again, important slide. Class 2 convex profiles have smallest airways. Class 1 patients are then follow. Class 3 patients have the best airways. So let's look at dogs. Let's talk about dogs for a little bit. So the dog to the right, which is the bulldog, actually those dogs they're great dogs. They live at the vet's office. These dogs don't have a very long life expectancy. They are very prone to getting upper respiratory tract infections. They have reduced nasal airflow. So you can kind of see and appreciate here compared to the yellow lab on the left, was actually a picture of my dog, how these patients that are long snouts is just very conducive to good breathing. So these crunched faces and reduced nasal airflows can lead to health problems. They can restrict forward skeletal growth and projection of the jaws and face during the growing years. They are more prone to upper respiratory infections. There's probably a strong allergy component. Some of it's structural and some of it is environmental. These reduced nasal airflow leads to rhinitis, sinusitis, basically ENT problems, sinus disease. Allergies lead to soft tissue edema, and think about that on a small child where the face is growing and the presence of soft tissue edema and inflammation. That's basically like a headgear effect, and so these jaws are not going to be able to project forward as much as we'd like to see. So we want to see nice, well-developed faces in terms of airway health is concerned. This is why orthodontists and pediatric dentists who understand facial growth, and I wish pediatricians too, are singularly positioned in a unique position to screen and affect suture growth of the face and reduce the incidence and severity of nasal airflow problems and screen for patients at risk for obstructive sleep apnea. So this is what's possible now in every single patient, and this is what we do. We look at the big picture. It really becomes our responsibility now and our obligation to understand patients' airway health and manage and develop their airways as part of our overall evaluation. So every single patient in our practice gets an entire cross-sectional view, these multiplanar views. We want to understand their complete anatomy. It's important to understand nasal cavity anatomy and sinus anatomy because that is the same neighborhood that we're dealing with. Remember that the palate is the same bone as the floor of the nose, right? So these airway assessments really become kind of like the hallmark and centerpiece of all of our orthodontic treatment plans. We work very much hand in hand with the ENT, the otolaryngologist, the pediatricians, and the allergists. So let's talk a little bit about these relationships and how they affect our cases. So we'll start out with this case here. So this is a patient who we had done orthodontic surgery, quite honestly, for the purposes of occlusion. He was class 2. He wanted to reduce his overjet, and he had orthodontic surgery. He had a straight mandibular advancement, and this is quickly the before and after. What I want to show you here is the effect on the airway. Now, we did this treatment on this patient without really understanding or fully appreciating airways at the time. And just out of curiosity, I wanted to go back and look at the change of the airway. Once I was exposed to some of these articles and studies, I said, let's go back and look at the effect on the airway after we advanced the mandibles. You can see pretty significant change. This is another case. It's a pretty severe case. This is Dominic. Dominic, at age 36, has an AHI of 92. We really didn't talk about AHIs, but AHI is the standard index, which stands for apnea-hypopnea index. For those of you who don't know, it's the score that a polysomnogram or a sleep study will give us. And so what is normal, a normal AHI is considered between 0 and 5. Mild sleep apnea is considered between 5 and 15. Moderate sleep apnea is considered between 15 and 30, and above 30 of an AHI is considered severe. So Dominic at age 36 has an AHI of 92, and normal is 5. So basically what this says is that Dominic stops breathing 90 times per hour in his sleep. So the guy's basically, dying in his sleep. He's a pretty severe case. So Dominic seeks treatment. He's tried CPAPs, he's tried lots of different therapies, oral appliances, nothing has worked. What's interesting about Dominic, if you start to kind of look at the teeth, is first of all, the degree of attrition and bruxism and signs of bruxism and wear and tear on his teeth, which more and more studies are coming out that bruxism in some cases seems to be a protective mechanism of the brain to protect the airways and to open up the airways. And it makes a lot of sense. Also interesting to note that Dominic is missing 4 premolars. And look at the size of his arches, very constricted. And so it's hard to imagine how, and Dominic's a big guy. He's probably 6'4", 300 pounds, looks like a bodybuilder. And it's hard to imagine how his tongue can comfortably fit in that oral, in that volume of tongue space in his mouth, basically. So Dominic decides to have definitive treatment in the form of orthodontic surgery. We ended up having a 2-stage surgery procedure. He had SARPI, surgically assisted rapid palatal expansion, followed by orthodontic surgery. Won't get caught up too much in those details. I just want to show you the airway that Dominic presents with. So he has an MCA. You can see it here in the black, very small. It's hard to see the number, but it was about 40-something. And again, we'd like to see that number above 150. Dominic was treated with something called medical modeling, which is computerized surgical treatment plannings. It's how we're doing all of our orthodontic surgeries done now. Using a high setting on our iCat, we can get a pretty decent resolution of the bone, the osseous tissue. Everything's segmented, everything is moved, and the surgical guides, surgical wedges, cutting guides are all fabricated off this. This information is then, the appliances are transferred to the operating table, and these patients are treated in a very predictable manner. You can see here some operative pictures provided by the surgeon, and you can quickly see here the MMA with the advancement genio. Most of these patients will benefit from having the advancement genio done because it brings the tongue forward even more. So sleep apnea cases, we always, no matter what they're going to look like, we always want to make them look good, of course, or better, but that's not the reason why we're doing these procedures. So sometimes they'll tend to have a kind of a strong, prominent chin post-surgically, but it's treating and resolving their OSA. So this is Dominic post-surgery. We couldn't wait enough before we captured a post-op picture of him. Again, his airway before treatment at 46 MCA, post-treatment MCA 347. So you can really, post-surgically, so you can really appreciate why those studies report that MMAs are the most definitive cure for obstructive sleep apnea, because now it has to be of the OSA nature. It has to be obstructive, and by definition, obstructive means anatomic. So by addressing the anatomy, we can arrive at a solution. So this is Dominic post-treatment. So teeth look great, arches have been expanded, face looks good, but Dominic is happy. He still has to get a new sleep study, but I can certainly tell you in Dominic reports he's breathing, he's a different person, breathing better, sleeping better, and of course living better. Quality of life at age 38 now. Here's another case. Patient comes in. It's a restorative case. Was referred to me by the periodontist to upright a molar for dental implant placement. We go through, this is why it's so important to have a comprehensive analysis of every case, not just do single tooth treatment, but very important here. When I looked at this, his mouth, I was seeing a class 2 patient, suspicious, according to the studies, class 2 suspicious of small airways. Sure enough, mandible set back, very small airway. We have a couple options here. We can do single tooth treatment, upright the molar, make a position, make space for an implant, or we can treat Tony more comprehensively, educate him. A lot of patient education is required. Talk to these patients. These visuals are great. Patients get it. They understand it when they see this. Everybody wants to live longer and healthier. So it does require a little bit of time, but you educate these patients. You explore their options. So we convinced Tony to get a sleep study, came back very positive. Sleep physician recommended a CPAP. Tony didn't want one. We went on to mandibular advancement, actually MMA. So a quick picture of his MMA with advancement genio, and before and after pictures. These patients oftentimes look a lot healthier, younger, profiles look better, their oxygenation changes. We give it some time. After months, you really see some of the health benefits in their skin and really in their overall disposition, personalities, fatigue, etc. Here's Tony's before and after Airways. We're going to be doing a lot of this, just looking at before and after Airways, going from an MCA of 47 to 394. Pretty similar to that previous case of Dominic. So these airways are being enlarged quite a bit. And so again, we're able to visualize this anatomy and isolate these airways on our cases. So, it comes to mind, it brings up a very important question is, how do teeth have anything to do with this? So, is there an orthodontic origin in Dominic's case? Now, it's not, I think there is. And I think that looking back in retrospect, Dominic probably would have been better served with expansion treatment and not extracting 4 bites. And if you have to live with a little recession or the need for connective tissue grafting, that of course is really becomes almost insignificant compared to the big picture of life and longevity. So just something to think about. Much of what we do orthodontically may affect the airways. So we want to think about questioning restrictive mechanics that we do on patients, such as headgear. So when headgear works great at fixing occlusions when you're just looking at teeth, but it's kind of backward to think about why we would want to restrict forward growth of the jaws when you think about airways, particularly on somebody who we can screen for that has a small airway to begin with. Certain treatment plans and mechanics really are contraindicated with patients that have small airways. We know that now. This is another patient that was treated, not by me, many years ago, had 4 premolars removed, had a good class 1 occlusion for the most part. The records represented a really nice result. This is probably board standard records and board standard measurements. Really treated to ideal, and the patient is 22 years old. The only problem is that the patient at 22 lives on a CPAP machine. So you kind of have to wonder if airways, if patients are being treated with airway information, and probably not because of technological limitations. We never had cone beam 20, 30 years ago. Let's take a look at Rosie's case. Another case, had upper premolars removed. Sounds like I wasn't there many years ago by her previous orthodontist. She had upper bites removed for one of 2 reasons. Either she didn't have room for her canines, so they took out some premolars for crowding, or to reduce her overjet. Turns out she still has overjet, is missing upper premolars, and has a very small airway. So you can see here that it's safe to say this patient was probably treated without regards to her airway. Again, not knocking everybody, just technological limitations at the time. But we are better positioned now, technology-wise. We know better from studies. We can see more. Patient has a very small pharyngeal airway in the black. No surprise, mandible is very retrognathic. Patient opts to be treated again. We do a comprehensive analysis. We're going to treat her with orthognathic surgery. We go through a process of decompensation. These patients oftentimes have to look worse before they can look better. Overjets increase. Patient has orthognathic surgery through medical modeling. I'm going to go through this kind of quickly. And you'll see here the before and after changes on her airways. So what I would like to see on most case presentations, not orthodontically, it's nice to look at occlusions and faces and cephalometric numbers, but let's also look at airways. What are the effects of what we do on patients? What are those effects on the airways? So MCA from 44 to 346. No surprise, consistent with the studies showing how airways can be enlarged with MMA. And this is Rosie's final case. She's very happy. And when we can do an all-encompassing treatment like this, when we can consider facial aesthetics and function and longevity, it really allows take better care of our patients, if we set the standard high, if we look at the big picture, and not necessarily be afraid to recommend sometimes more difficult, more invasive treatments, but we know that maybe it's the right thing to do for the patient. We're going to speed this up a little bit because time is going kind of fast, so give me a second here. Okay, let's look at this case. What about expansion on adults? Okay, we're going to start looking into expansion because that's kind of like, it's going to end up being very much the framework of this talk is expansion in light of these studies that are coming out with the facial skeleton. So adult patient, obviously maxillary constricted. You can just tell by his facial features. This patient is a mouth breather. He is struggling to breathe through his nose. You can see the gingivitis, the bilateral posterior crossbites, the maxillary constriction in the form of crowding as well. Cone beam oftentimes allows us to detect pathology, always take care of pathology first. This particular patient had an odontogenic tumor which had to be removed. Patient was then treatment plan for something called SARPI, which stands for Surgically Assisted Rapid Palatal Expansion. So this patient needs expansion, palatal expansion. And palatal expansion cannot be performed, according to the evidence, on adult patients who are done growing without I mean, you can move teeth, you can tip teeth, but you can't really expand the palate at the sutural levels. So these patients have to have their jaws broken for expansion to work. So we're just going to fast forward this. So this is the final results of the case. Patient after had SARPI. Patient needed a TAD at the end of treatment, a temporary anchorage device to kind of control the occlusion a little bit. And let's look at the before and after. So first of all, the face looks much better. Patient looks healthier, wider smile, certainly a much more attractive smile. The teeth look great. The occlusion looks much improved. Here's the coronal views. You can see what actually happened in the transverse dimension, how the nasal cavity and the sinus wall was actually, the sinus cavity was actually increased. These beautiful arch forms you can see now with these cone beams. And you have to think, with these expanded arch forms, the tongue is everything. The tongue can certainly live much more comfortable in this environment on the right than this environment on the left. The patient has been also converted from a mouth breather to a nose breather. And what's most amazing here is the pharyngeal airway change. Went from 156 MCA to 416. So pretty significant changes on these adult patients that are being treated with orthodontic surgery. So Maria Tullis is the program director at Harvard, Massachusetts Mass General Hospital. And she stated that the new goal of oral and maxillofacial surgery is the expansion of the craniofacial skeleton. Please keep this in mind as we move forward in the presentation. So oral and maxillofacial surgery is not a four-letter word. It's an invasive procedure, but it can save lives for people. Nevertheless, it's an invasive, difficult procedure, and it makes you appreciate the importance of treating children early on when you can really, such as myself, involved in adult treatments of this extent, makes you go back and want to look at the children differently. Let's talk about this. And I'd like to make a couple of suggestions in Maria's quote and change a few things. So let's make orthodontics, let's revisit our goals, and let's make the new goal of orthodontics the expansion of the craniofacial skeleton in growing children in light of obstructive sleep apnea, and our position to treat patients not so much for their current status, but when they're 40 and 50 and 60 years old. So think about facial orthopedics on children through the use of manipulating these craniofacial sutures, which are really not viable or available after a certain age. Enloe from Case Western demonstrated that 95% of the face is done growing by age 12. I'll say that again. Enloe showed that 95% of the face is done growing by age 12, because these sutures, which begin to fuse at birth, finish fusing in the early teenage years. So we're really limited with what we can do skeletally on patients after age 12. So if I had my preference, I would prefer that doctors don't refer cases to me after age 12. It's almost too late at that point. After age 12, I'm limited. I just become a tooth straightener at this point. I cannot really alter the face as much. So Save the Children is really what this is about. And this is a motto not stated by me. This is stated by Christian Guilleminault. Christian Guilleminault, for those involved in sleep medicine, is really known as one of the pioneers and leaders of sleep medicine. He's out of Stanford University, where they're doing a lot of these studies on sleep, on the treatment of sleep apnea, and really helping us understand the anatomy involved in sleep apnea. So Christian Guilleminault is about to retire. I think he's in his 70s, close to 80s, and he's dedicated the last decade or so of his career to studying sleep apnea in children and seeing how that can be detected and prevented. He's been involved in a lot of research projects. Unfortunately, most of the literature talking about the effects of rapid maxillary expansion on sleep apnea in children are actually in the medical literature, surprisingly, and not in the dental or orthodontic literature. But there's a lot of evidence now coming out in the medical field showing the effects of expanders on children and the effects on sleep apnea and the resolution of pediatric sleep apnea. So we talked about different solutions for sleep apnea on patients, but we didn't talk about the most effective and the least invasive, which is prevention, early intervention, and early screening. And we can do this now understanding these anatomical relationships with this cone beam technology. So do we see large airways occurring naturally in nature on 8-year-olds? Yes, we do, and we see them all the time. So just because a patient is young and their bodies are small and their faces are small doesn't mean that their airways have to be small. So it is possible to have, we do see airways, large airways on young children. So this is what we need to do. We need to screen for these small airways on children and look at our treatment a little bit differently on these patients. So we're going to fast forward here to this case that I want to show you. Well, actually, you know what? Let me show you this case here. So this is a young boy that we had seen this video early on. And sure, this patient has crowding. This patient has ectopic canines that need to be addressed. This patient needs to be expanded. And eruption management is important. But when you really look at this airway, this is quite frightening. This patient is basically suffocating. For sure, this patient has obstructive sleep apnea. And so it's easy to make the referral to a medical team to manage this patient, but also to consider the effect of facial orthopedics in trying to help promote facial growth. Because just as we saw in those orthodontic surgery cases, as the face is brought forward surgically, those airways are improved. Well, what about the face during growth? If the face can grow forward, should we not expect the same kind of improvement in the airway? That's kind of an important parallel and important question. So let's look at case study number 1. So this is a young boy who came in. Parents were concerned about the teeth coming in. I took a look at the boy and I was a little bit concerned about the general facial appearance. Looked like a mouth breather, looked allergic, looked tired, droopy eyes, kind of dry mouth, clearly signs of a mouth breather. So we went ahead and did a full head screen, a full extended field of view cone beam on this patient. We wanted to look at the big picture. And sure enough, what did we detect? We discovered supersized adenoids. I mean, look at the size of these suckers. They are just humongous. And no wonder that they are causing a significant obstruction. And if you look at the black, we can identify why it's black, because the adenoids are obstructing the airway. So allows us to identify the problem, get the right solution for the patient. You can see here, smallest cross-sectional area is right here, the black, right at the level of the adenoids. Sometimes it's at the tonsils. Sometimes it's neither. And sometimes it's just because the mandible or the maxilla is back. So anyway, quick, easy reference. These visuals are great. We can do quick screening. We can help educate the parents about these things. Patients really understand. So this patient had a mucus retention cyst, which is very common, no big deal. But what's interesting is these patients with large adenoids typically have other airway-related issues going on. So the adenoids, I have found in talking to ENTs, they see the same thing. The large adenoids seem to be the epicenter of these airways and sinus problems, they seem to be kind of the beehive. Patients with large adenoids usually don't have this isolated problem. They have sinus disease elsewhere. Turbinates were enlarged, so the patient was referred to first ENT management, had adenoids removed, had the turbinates reduced through something called coblation of the turbinates. And then we went in to perform phase 1 facial orthodontics to expand the maxilla. Our particular treatment involves an RPE to the first molars with the brackets canine to canines. I like to wait until the upper anteriors are in because we can, I think, get a little bit of better expansion. We can also make the teeth look a little bit better, and we can accomplish more at once. So treatment efficiency is kind of a big deal. We want to accomplish the most we can in the least amount of time and invasiveness and cost for the patient. Mandible, no doubt, much more difficult to expand. We don't have many tools. I particularly like to use a lower Schwartz. And what we're doing here, on many levels, many things going on, but one thing that expansion does is it makes more room for the tongue. Anything that makes more room for the tongue is good for airways. So I'll show you here the before and after images of the patients. We scanned the patients 2 years later. The patient was probably 8 years old at the time. Again, you can see the MCA went from 10 to 304. Quick visual. Again, you can see this is just a massive improvement in the airway. I mean, this is just like a river of oxygen coming down through this windpipe now. So you guys are all experts on colors now. It's nice to see these colorful changes on the patient's airway. But what's remarkable here went from an MCA of 10 to 304. If you recall a few slides back, these are the type of changes that we were seeing on orthodontic surgery cases without the surgery on young kids. So how can we not go back and think about airways on children? Again, these are the kind of changes that we're seeing on adult patients undergoing very invasive, very aggressive oral and maxillofacial surgery procedures known as maxillomandibular advancements. So think about how this translates to children. If we can detect problems and screen for kids at risk and perform mechanics that help, anything that helps promote facial growth on children is good for airways. So let's look at the before and after photos. So of course everybody's happy when their teeth look pretty. Moms are happy, parents are happy, straight teeth are nice. But interesting, look at the humidity, look at the moisture of the oral cavity. Patient went from being dry, oral breather to a human nose breather. Look at the facial changes. Notice the droopy eyes. Notice the edema, the overall appearance of the face, the facial edema and swelling compared to this face here. You can see the color of the skin. This patient looks oxygenated, much healthier. So there's a 2-year difference. And look at the change in the profile. So as that mandible grew, as that face grew, so did the face. So this case is very dear to my heart because this patient I treated a while ago, I learned so much from treating this case. But this patient, I'll tell you, is living a lot better. He is sleeping a lot better. He's breathing a lot better. And I know this because this patient is not only my patient, this patient is my son. This is my son who is now thriving at age 12. So, of course, when you treat your own son and you make a life change, or you notice a life change like this, you have to go back and you have to revisit the case, figure out what it is that we did, and learn from it. So, this is a simulation of this original scan of what I think happened. I think what happened here is we agitated those maxillofacial sutures. Of course, removing the adenoids was first and most important. And expansion treatment is so easy to do on these kids. By agitating and stimulating these craniofacial sutures, that maxilla gets released and can come forward again. And that maxilla needs to be wider, significantly wider than the mandibular arch for that mandible to come forward. It's kind of like the foot in the sandal scenario that James McNamara talks about. If you envision trying to put your foot in the sandal, you're going to be limited by the width of the sandal. The minute that you get a wider sandal, now you have the geometric relationship where that foot can project all the way forward. It's very simple. You need a wider posterior dentition for that mandible to free up and come forward. So this is a T1 and T2 superposition using cone beam 3T data, superimposed on cranial base through computer algorithms. So we can see here exactly what happened. It's not what I think happened, it's what actually happened. And quite frankly, what we're seeing here is the face coming forward, very similar to what we see with orthodontic surgery cases. So we need to be encouraging and promoting facial growth on our patients for purposes of airway. But JC, this is a sample size of 1. Come on. How can you make those claims? Well, because the only thing more powerful than the power of statistics really is the power of genetics. And if you go back and you look at my father's airway, so this is grandfather, look how small his airway is. Look at my airway. Look at my son's airway. So, we inherit our parents' faces, and we inherit their immune system. And so environment and genetics play a big role. So look at my son's airway now. So the joke goes, I may not leave my son a lot of money, but gosh darn, I'm going to leave him a good airway. So we published this case in Orthotown 2001. It's 2011. It's available. So this is my other son, Snaggletooth Lucas, who's at age 7. And do you think, in terms of screening goes, after what I saw with my patients, that I was going to have any reluctance to scan my 7-year-old with an extended field of view scan? Heck no. And boy, am I glad I did, because look at his scan at age 7. Look at his airway. Very small. Consistent with what granddad, dad, and brother had. We all have small airways. So I did not hesitate a minute to take a scan on him and put him in an expander. What's interesting about Lucas's case is he has no problem with adenoids, and he has no problem with tonsils. His mandible is just back. So we went ahead and performed phase 1 early treatment. It's so simple to do. Put an expander in, bracket the teeth, unlock those sutures, unlock those mandibles, sit back, wait a couple of years, let them grow. And what we have here is a pre and post airway comparison. MCA went from 44 to 281. Wow. Pretty remarkable. Pretty remarkable. So, we're going to talk a little bit about whether this happens alone, by itself. What if we don't treat patients? What happens? When it comes to your kids, you're not going to mess around. And so, I'm glad I treated my kid with an expander for purposes of airways. We're going to fast forward a little bit. We don't have much time left. I want to show you one very important study that is the only study that I have found that looks at normal airways. So this is a study that recently came out of Stanford. You got to really pay attention to these Stanford people. They're onto something. They got some great airway studies coming out. So they looked at, they asked the question, what is normal? What is normal airway on patients? So they looked at 1,300 subjects, all with cone beam from all age ranges, and they wanted to see what their airways looked like and be able to graph their airways and have an idea of what normal is. What can we expect? And what can we expect from aging? Because interestingly, in the study, the ages ranged from I think age 6 to all the way to the 80s and 90s. So this is a graph that comes out of the study. It's just reporting here the different sizes of their airways. They looked at volume, but this is what's very interesting to me, the smallest cross-sectional airway. And so it looks like airways grow early in life, and they max out between ages 20 and 30. So it's really nice. It's a quick reference guide. We can look at the age, and we can quickly look at what is normal for patients. Okay? Now, something to understand here about the pool of patients. These patients were taken out of an orthodontic office. Okay, so there's a little bit of a bias going on. So you figure if these patients are coming from an orthodontic office, they are patients with orthodontic problems. So the data is a little skewed towards patients that maybe have small airways to begin with. So I have a feeling that this is not so much normal data as it is common data from an orthodontic practice. But this is the best that we have. So let's look at this. This is just a chart that looks at age distribution and the MCA. So you can see with growth, we can expect the MCA to grow. It'll peak out on age 20 or 30, and after age 50, it just takes a nosedive. So the smallest cross-sectional area will really begin to diminish after age 50. So something to think about. We have to think about treating patients to a good airway, especially after age 50. So you can see here, there's another slide, and what you can see here is that you can expect there's a general rule of thumb in terms of this study anyway, is that just multiply the patient's age by 10, and that's where their smallest cross-sectional area should be. So this patient at age 8 should have an NCA of 80. This patient at age 10 should have an NCA of about 100. All right, so those patients their airways should be growing every year. Okay, so we're going to wrap this up. A couple of conclusions here in the summary. Save the children, very important. Think about airways on children. And running out of time here, so I'm going to open up the floor for some questions at this point. Thank you for your attention. So we had to rush it towards the end there. I do have a website that I've developed that talks about this. The intention is for patients. It's called Airway Development. It's a blog. We try to publish once a month and report like a little chapter of the airway story. So I'm going to go ahead and take some questions.